Action.
Musky.
Yes, sir. Arun Musky, sir, I think there is a connection problem. That's why he couldn't join still. But many of the participants from Nepal has joined already.
Right.
আচ্ছা তাদেরকে ইয়া করো মানে তারা যাতে করে পার্টিসিপেট করতে হবে বুঝছো তাদেরকে এখনই ইয়া করে ফেলো
Dr. Nabila.
কানেক্টেড করে ফেলো হ্যাঁ
Please look at the list and আমি তোমাকে বলছি কি করতে হবে
I have changed the role to panelist student.
এই তুষার ওই সাউন্ডটা দেখতে আছে
স্যার আমরা একটু মিউট করে দিচ্ছি unwanted sound for change we will make all the participants video visible on our and this meeting today so that we can have face recognition and can have their answers as well. So they will be in our panelist list.
Oh, please do that.
Rohit sir, আপনি 31 তারিখে আসতেছেন স্যার?
হ্যাঁ।
Okay.
Sociology, anthropology.
Sir, inshallah we will do a program on আপনি যেটা বলছিলেন স্যার নভেম্বরের 16 বা 17 তারিখে সম্ভবত আমরা চেষ্টা করছি স্যার প্রোগ্রামটা করার আপনাকে স্যার একটা গুরু দায়িত্ব পালন করতে হবে স্যার সেটা হচ্ছে স্যার ইসিজি কুইজ একটা রাখতে চাচ্ছি স্যার আমরা এবং কুইজটা স্যার আপনার ইসে হবে স্যার
ওকে ঠিক আছে
ইসিজি কুইজের ইসিজি এবং কোশ্চেন এটা স্যার আপনার তত্ত্বাবধানে
Sound good, sir.
Oh, hello. Thank you, sir. Thank you, Maski, sir, for joining.
Thank you. Assalamu alaikum, everybody.
Adil sir, assalamu alaikum. Adil sir, assalamu alaikum.
Assalamu alaikum, সবাইকে।
Ready for you too, guys. Right.
Hello. Hello.
Tushar, can you hear any noise from my side?
Sir, I think there is some noise. On the background, probably,
Okay, just look at it because I have somebody in the other room.
yes,
Can you
sir.
hear
I
something?
think,
Can you hear something now?
no, not
Okay.
now, but there was some noise.
Okay. I'm going to turn the mute it, see if you notice any difference.
So
Now
there
it is
now
clear,
there's
sir.
no sound on the background.
And now it is
There-
okay, sir.
How about now?
It's totally soundless.
Oh, okay.
Dr. Nabila, please start the proceedings so that we can start the session.
Okay, okay.
You may now start.
Okay. Assalamu alaikum and good evening, dear participants. Respected physicians, today we have 77th lecture session and ECG Basic and Beyond series organized by ECG Study Group. Today, our speaker is none other than our well-renowned and popular, our most respected teacher, Dr. Rafiq Ahmed sir. Sir will deliver his speech on basic and case studies in ECG. Before the start of the lecture, I'd like to request Professor Abdullah Jamil sir to say some words regarding Rafiq Ahmed sir, and then I request sir to start the session. Abdullah Jamil sir. Jamil sir.
Sorry, I was muted. Assalamu alaikum. All of us know about Dr. Rafiq Ahmed for long time. And since 2004, I am in touch with him and learning so many things from his lecture and other means. And he, the person for whom we are now electrophysiologist in Bangladesh, and he started it with the machine in NICVD, and I was lucky to be with him working in NICVD for a while. EP was started, and he knows how to make a complex thing very simpler way to deliver in a lecture, and which is very palatable for every person, especially what the beginners. They can easily grab it when Rafiq sir delivers something in his lecture or in a tutorial. So I would not kill more time. I would request Rafiq sir to deliver his lecture.
Thank you. Good morning. And of course, good evening over there. Thanks everybody for joining. So, I mean, I was deciding what to do, but as usual, I'm going to go over ECGs. We'll have some choices and please answer. I request all of you to answer. It doesn't matter. It's not the question of right or wrong. It's the question of what you think of this ECG. And that's what it's all about. And then we'll go over it. So this is my first one. This is one of our patients who is 79, ischemic cardiomyopathy, has a defibrillator in place, and this is the ECG. So do we have choices, the poll? Fisher?
কামরুল পোল দাও।
Dr. Nabila, please arrange the poll for 15 seconds. Okay. Stop the poll, please.
Okay. Sure. So interesting. Quite a lot of people answered. And majority said atrial fibrillation, sinus rhythm with right bundle branch block, atrial flutter, non-CD ventricular tachycardia, and good. Can we have somebody from the audience to come and at least one person who said atrial fibrillation?
Tushar, Manoj Koirala, raised hand.
Okay, sure. Manoj,
Nabila, please make Mr. Manoj audible.
Yes, sir. Yes, sir.
Manoj, good afternoon. Good evening.
Good evening, sir.
So what do you think? Your choice was what?
Yes, sir. Atrial fibrillation with.
Okay, sure. And fine, tell me why you thought atrial fibrillation with right bundle branch block. Manoj got disconnected. Yeah.
Yes, sir. Now connected, sir.
So you said AFib, right? Atrial fibrillation. It looks irregular,
Yes,
right?
sir.
It looks irregular.
Yes, sir.
But is it really irregular or is there a pattern? So if you carefully look at it, first of all, it is wide QRS, right? Some of the lead, it looks
Yes,
kind
sir.
of,
It's like. Yes, sir.
okay. But if you look at the, if you,
They're coupling.
I'm sure you can see my pointer, short, long, short, long. So it is not really irregular. There is a pattern to it, right? I agree with that. Yeah, there is a
There's
pattern.
a pattern of coupling.
Coupling. And that's why I put a second choice, sinus rhythm with right supraventricular premature beat. That's a possibility. Atrial flutter is also a possibility.
Yes.
Now the question is, let's look at it. So what I did, I said, is it possible that this is VT? And I looked at options. And in VT, we look at concordance. That means if all the QRS complexes were positive in V1 through V6, it will be VT, but it's not concordant because V1, V2, V3 is upright, V4 upright, but V5, there is a S wave. So it's not concordant. So that point is no good for this. So we go to the next point. What is next? We look at criteria in chest bleed from the beginning of the R wave to the deepest point of SOB, any precordial lead. If it is more than 100 milliseconds, it's VT. So I took this QRS complex, which is marked as V, and expanded it. And if you look at it, it's 1, 2, 3, a little bit over 3 boxes. So it's 120 to 130 milliseconds. So that fulfills the criteria of VT. But one criteria, is that good enough? Maybe, but let's look at something else. There are other, so it can be VT. So other criteria will be, is there AV dissociation? The problem is, I really cannot see any evidence. If I follow this lead too very carefully, I may be able to find something, but not really that I can convince you that there is AV dissociation. So that point is out. Then I looked at, is there morphology criteria for VT in lead V1 to V6? And these are the criteria that if this ECG looked left bundle, it will be like this, which it is not, but it looks right bundle, we will use one of these criteria. And then if I look at lead V1, it fulfills this criteria, QR pattern, and you can see QR, that's 1. And if you look at lead V6, the ratio of V1, R wave to S wave, less than 1. And if you look at V6, R is smaller than S. So this is actually a VT. Interesting. But your diagnosis, absolutely, it looks, and the reason, the question, your question will be, why is it then irregular? This patient had a defibrillator. The defibrillator was set at a VT detection of 120 beats per minute. And when we pulled up the intracardiac recordings, it was clearly VT. There was evidence to say, I have the slide in other place. I didn't want to put it there. But why is there irregularity? We know that VT is always regular, but is it always true?
No, sir. It is not always true.
Not always true. Absolutely right. And there can be two kinds of irregularity. One is if there is an automatic VT, you can see initial irregularity and then it becomes stable. But re-entry, so the re-entry, so by two criteria now, onset of R to S wave more than 100 millisecond and morphology criteria, two criteria fulfilled, this is VT. Now, so what we look at is, we look at re-entry. Let's say if there is a myocardial infarction scar here, there is a scar here, and there is healthy tissue, and you can produce re-entry. So the way it works, that let's say this QRS is the last QRS, it exits here, it goes through this circuit, and then when it comes out, it produces this QRS with this kind of interval. And the next beat, so this is the QRS, and then it will start going backward again. It's going backward. And then if there is another channel, if that is open, it takes less time, and then it comes down, it produces a short R interval. And again, if the next one finds this, because now this is refractory, next one comes, this finds the refractory, and that's how it patterns. That's the hypothesis of this kind of bigemini pattern with VT. And even though it's not relevant, it's a little advanced, but this patient has slow VT. Treatment would be, we can either give drugs like amiodarone, sotalol based on ejection fraction or blood pressure, or we can send the patient for ablation. What they can do, during ablation, we will go and find this common pathway. Probably not here, because if I ablate here, it can still continue VT here. So we'll have to map it and find the common pathway and exit point over here if we can ablate. And this is possible with 3D mapping nowadays. So please keep an open mind. When you see irregularity, look at the pattern of the ECG. Sometimes this QRS, if we suddenly look at lead 3 or some of the leads, it may look narrow, but if you carefully measure it, it is a wide QRS. And then you look at the pattern into this. Thanks, Manoj.
Yes, sir. Sir, I have one question, sir.
Yes.
Sir, in this lead 5, this is the terminal part of T wave. There is a positive notching. Is it P wave, sir?
It's possible. That's why I say that some of the leads I can see some notching, but to really say AV dissociation, I have to find it in multiple places. Because if I find in one place, one can say it is only artifact. But if I can find in multiple other places, so you look at carefully, and when the VT is very fast, it's difficult to find the evidence. It's easier to find during slow VT. Thank you. Any other question?
Thank you, sir.
No.
Rafiq bhai,
Yes.
I have an interesting thing to tell you, that in this one, there are two distinct coupling intervals, right?
Yes. Yes.
So if someone finds that it is tachycardia and intermediate QRS tachycardia, that the only way to explain is the VT. I don't think that we can explain anything else, because the coupling intervals are two distinct coupling intervals. Atrial flutter with variable block cannot explain.
Yes.
Definitely atrial fibrillation cannot explain.
Yes.
And in atrial flutter with fixed block cannot explain.
Yes, absolutely right. I mean, I put those choices. If it is atrial flutter with variable block, you will not see this kind of pattern. You can actually see this pattern if there is a Wenkeba, sinus with Wenkeba, but I don't have any P wave. So I think it's for the multiple choice question, if I'm sitting in exam, I will not pick a fib. I will not pick AV atrial flutter. I will then debate between sinusoid with Vankeba with VT, and probably I'll opt for VT. Even if, so that's the trick of multiple choice question.
That's how I was saying that by exclusion, someone
exclusion.
can get the right answer.
Yes. Yes. I mean, that's when you sit the exam, but in the real life, when my patient is sitting in front, please remember, it's not an exam, it's patient's life. So exam part, of course, we'll have to tackle, but also the real life, we have to tackle this.
Well, in exam, in real life is easy, right? Patient with previous coronary disease and intermediate QRS tachycardia, you entertain VT, of course.
Yes, thank you. So this one. Most of this ECG today will be pacemaker related. I thought it would be good to discuss these things. We have, can you have the poll, please? Is the poll up? Yeah. Please keep it for a few, maybe 30 seconds.
এই আরো সবাই আনসার করা উচিত, ভুল হোক শুদ্ধ হোক।
Yes, absolutely. Only 2 people answered. Can you put the poll again and have let's more people answer?
তার একটা প্রবলেম হচ্ছে নেটওয়ার্কে খুব মানে কানেকশন হচ্ছে চলে আসছে, এই জন্য বোধহয়।
Sure, I am proud possible.
Anyway, 50% out of 2.
No, it's, I need, please redo the poll. I need a new poll.
Sir, there is a problem that panelists cannot participate in the poll. As we are all participants, we cannot participate in the poll.
We know that. That's why I'm saying that only 2 people answered. Can you restart the poll?
এই পোলটা আবার দাও না।
স্যার ট্রাই করছি।
Okay.
6 people answered, so.
Okay. So majority said atrial pace rhythm, sinus rhythm with left atrial enlargement, and nobody said dual chamber pace rhythm and ventricular pace rhythm. I want the person who said ventricular pace rhythm, if you could be kind enough, let's talk about it. Or anybody else?
Sir, good evening, sir.
Hi. You are?
Sir, I am Dr.S.M. Sharma.
Sure. What do you think is this?
Sir, I think it is atrial pace rhythm, sir.
Sure. So I mean, you're absolutely correct. And then I did not put other diagnosis with it. When we say atrial pace rhythm, if you follow my spike, you can see the atrial pacing spike, P, then QRS complex. I also have to discuss the QRS complex, ST6, and everything else looks fine. It is not sinus rhythm because there is a pacing spike and it's consistently present. Dual chamber pacemaker, there was an answer before, it's a dual chamber pacemaker. Maybe the patient has a dual chamber pacemaker, but at this point, it's only pacing in the atrium. So from the ECG, I cannot tell if it is a single chamber pacemaker or dual chamber pacemaker. And to answer the ventricular pace rhythm, it is not ventricular pacing because there is no ventricular pacing spike. So this is atrial pace rhythm. So please remember, a lot of times we will see it, yes, atrial pacing. If the PR was long, probably it will come back with dual chamber pacing. Thank you.
Yes, welcome.
Sir, most of the time, the pacing ECG we have, even with atrial pacing, they have very small spike, and most of the time you cannot actually see. But what you can see, there's a fixed rate sometimes.
Yes.
If you put the magnet in there, then you can find out actually.
Yes. The older pacemakers with unipolar pacing would show spike better than a new pacemaker, bipolars. That's one. Secondly, the filtering mechanism in the ECG a lot of times eliminates. And there is another problem. There are newer machines which put spike when there is no spike. So I want on this one, please. Thanks, Chitra. Can you have a new poll, please?
A poll দাও। না, আগে চয়েসটা দাও, চয়েস দিয়ে তারপরে এই দিলে ভালো হয়। কামরুল চয়েস গুলো দাও।
Yeah, no, it was up. We got the poll. Poll is ongoing. Good. So we're everywhere, even though 5 people answer. So I'm going to go 2 ways. One, proper diagnosis if it is. Secondly, the trick of a multiple choice question. If you look at the QRS complex in chest leads, it is less than 10 millivolts, so definitely low voltage. All the choices have low voltage except the first one. So even if I did not know what the rhythm is, I will exclude that one because I am sure that this is a low voltage ECG. So sure, sinus rhythm is a choice with left atrial enlargement with PVC. Ectopic atrial rhythm, of course, the computer, if you look at, I put this computer ECG diagnosis. Ectopic atrial rhythm with PVC, and then low voltage, non-specific T wave changes. Atrial pace rhythm, sinus rhythm with low voltage. Look at this, I have 2 excluding diagnoses. Sinus rhythm, low voltage, PVC, non-specific, and first one did not have, so that should have been out. And what Wadud was mentioning is I have now magnified this ECG. If you look at it, I have magnified lead V1. Yes. And look at this, you can see the pacing spike. If very minute in this here, but this one, I can clearly see it. And then if you follow in other leads, you can see the pacing spike, lead V1 randomly over there. So this is what Wadud was mentioning, that sometimes it can be very, very difficult to see this spike. Now remember, when I see this ECG, I don't have the patient. A lot of times what I will do before I report the ECG, I look at the chest X-ray just to make sure it's not an artifact. So it's not that I know it all, but I verify it. And that's the way beauty of medicine is that you have to number one, diagnosis, initial diagnosis, collaborate with other findings. Second thing, when we diagnose something that we must confirm, like the ECG that I showed in the beginning, VT, I confirmed that was VT by intracardiac recording, and that confirmed my knowledge and reinforced my knowledge of this. So you have to not believe what I say. When you find ECG, you must make sure that over many years, you continue to culture this thing, that I want to confirm the diagnosis to level of absolute confirmation. And that creates a fundamental basis of knowledge. Anybody, any comment? Wadud or Atar, Hafiz, Ajij?
No, I think I totally agree with that. And the reason is, sometimes I'm giving an example that most commonly we see, like early repolarization pattern on the EKG, okay? If the patient comes with, they're not very clear early repolarization, but some minor ST elevation, but always you need to look at the clinical symptoms of this patient. If the patient comes with chest pain, sweating, suggestive of acute coronary syndrome, and computer is reading early repolarization, you need to verify that because sometimes we do mistakes. So in those situations, definitely, I always try to look at the note, look at if the patient is there, I sometimes even go and look at the history. So clinical symptoms verification is very important, because computer reading is, if it's normal EKG, almost 100% accurate, okay? But abnormal, don't believe it always. That's the way I would put it there.
But I always have one thing about normal ECG. If you can diagnose normal ECG, and if you are correct more than 95% of the time, you have actually taken care of 90% of your patients, because 90% of patients in clinical practice will have normal ECG. And it's very, very important to be confident about normal ECG. And once you do that, you exclude 90% of the patients. So this, I'm not going to don't put the poll. Again, same thing, that if you look at, I have choices: sinus rhythm with left-handed element, ectopic atrial rhythm, atrial paced rhythm, sinus rhythm with voltage criteria for LVH. Now look at this. There is a pacing spike.
Yeah.
It's very difficult to see. When I enlarge it, I can see it before each QRS complex. And so there is no doubt this is an atrial paced rhythm. And that's the difficulty. And especially if you make a photocopy of it, it even gets worse. So this is the ECG. Those of you who are in the audience, if you think, wonder why do I get this ECGs from? Anytime I find an interesting ECG, I scan it and I put it in the computer. And I write down a little bit of background. And if you do that practice over a period of lifetime, you'll have thousands of ECGs, and try to write down a little bit of history of that. When we started, we had to make photocopy, we had to make slides, but now it is so easy. The other thing is that do not take the picture with the camera, because then you distort the grids. If you want to save it, you have to scan it with a scanner so that the calibration and everything remains good. And other thing you do when you make a slide, never expand the slide laterally or top to bottom, because then you are distorting the ECG, you are distorting the grids. If you want to expand it, you have to expand it from the corner so that it looks, the proportion remains same. So I want this one. This is interesting. ECG, simple, but I thought it was interesting. Paul, please. Okay. So Anybody wants to do it, or you want me to do it? Okay, I'll start. Number A. A was sinus rhythm with left ventricular hypertrophy by lymph lead voltage. Sure, there is a high voltage ECG in lead 1, and P wave looks upright in lead 1 AVL, maybe sinus, but there is a pacing spike before each of those P waves. So that takes away sinus rhythm with left ventricular hypertrophy. Ectopic atrial rhythm, for the same reason, you can say ectopic atrial rhythm because lead 3 is negative, lead AVF is negative. And the P wave in other chest leads are funny, but again, there is a pacing spike. So ectopic atrial rhythm is out of the question. Now, atrial paced rhythm with left ventricular hypertrophy limb voltage criteria is a possibility, and dual chamber pacing with pseudofusion. Look at this ECG. This QRS, it doesn't look normal. It looks kind of somebody have drawn a line on the QRS complex on the top, not regular QRS complex. And same is in lead V1, you can see this sharp deflection. So what happened here? There is a long PR interval, there is a pacing spike, which is on the QRS complex. And basically it's a dual chamber pacing with pseudofusion. That means it did not fuse. And I'm going to show you the same patient's ECG. If you look at, this is same day before the pacemaker was implanted, July 9th, 11:55, and after pacemaker implantation. So basically the QRS is this height, and look at this lead 1, V1, there is nothing. So, and this is just a pseudofusion. You will see sometimes this kind of ECG and that pseudofusion. And the difference between fusion and pseudofusion is that QRS does not change, but there is a pacing spike on or just at the onset of QRS complex. Anybody else, any comment?
Now, I think if you look at that, I think Dr. Rafiq sir already mentioned, but one thing that just visually look at it, that rhythm history, okay? And look at that each QRS complex, there's after a few QRS complex, you see change of the QRS complex. The smaller, and then again getting normal, and then again smaller. So when you see that abnormal, there's some change in pattern of the QRS, there's something going on there. And you see a spike there on top of that. So definitely it's pseudodiffusion going on. So
sure, thanks.
So may I have a question,
yes,
sir?
Please.
So in that ECG, the PR interval looks like 140, 160, sir. Even then the ventricular spikes are coming, sir. Is it like, is this possible, sir?
Okay, PR interval actually I measured is 268 milliseconds.
Oh.
Because if you look at the spike, that's when the PS started. So here, one big box and then 2.5.
So we have to measure from spike or actual P wave, sir?
Well, because you have to measure from the spike. It's paced.
Paced rhythm.
Mm-hmm. Because the activation starts at that point. Mm-hmm. And there is some, yeah, because the pacemaker is programmed from the spike.
Oh, okay, sir.
And sometimes we allow it some duration, more duration, so that the natural, QRS complex can occur. So there's especially, we are delayed there, so it doesn't pace all the time the V lead. But if it doesn't occur, then V lead comes up. So slight, longer duration, we naturally allow that on the pacemaker.
Okay.
Thank you, sir.
Heart rate is 70 beats per minute. It's regular. So, poll, please. Okay. I think these are, everybody has chosen everything, which is good because that's where the choices are. And I'm going to go with this. So atrial surge ventricular pace rhythm. Sure, there is something like a P wave and there is a QRS. Something like a P, there is a QRS. But look at here is different. And there is this wiggly lines, which does not look like sinus. Lead 1, if it is marked first degree VBOC, I can call this P wave, but look at lead 3, there is nothing. So I don't think this is a possibility because you have to follow one lead, like lead 2. You don't see a definite P wave. Here it looks like a P wave, but here it doesn't. That's one. Sinus rhythm with left bundle bunch block, sure, by the QRS morphology, lead 1 looks like left bundle, but there is a pacing spike before each QRS complex. So definitely it's a paced rhythm. And that also takes away accelerated idioventricular rhythm. This is ventricular paced rhythm with underlying atrial fibrillation. So a lot of times, even a lot of physicians will look at this ECG, just report it as ventricular paced rhythm. It is important to report the underlying atrial fibrillation. Why? Because then you have to treat the atrial fibrillation. That means you have to anticoagulate or you take care of other problems. Sometimes you'll see a patient who was in sinus goes into AFib. So if you don't pay attention to this, you will miss this diagnosis and you will put this patient, most importantly, to risk of stroke. So it is always important to write down what the underlying rhythm is. So the other part is that you cannot tell from this ECG whether it is a single chamber pacemaker or dual chamber pacemaker, because most modern dual chamber pacemaker, once patient is going to AFib, it will mode switch to ventricular pacing only. Thank you.
And Dr. Rafiq sir, I'd like to make a comment on that. This is a very important point to make because computer is going to read V pace rhythm. That's all it's going to read. And in practice, we see that even you see that, and you definitely need to mention that with underlying atrial fibrillation. Please add that diagnosis. Computer doesn't do that. Computer simply does V pace rhythm. That's it.
Absolutely.
So, and since the clinical implication is very high, I have a lot of times I had to call the patient's doctor or the patient that you need to be on anticoagulation. So just keep in mind the clinical implication of that.
Sir, another thing is that the patient have very regular rhythm. There must be complete heart block as well.
Absolutely. Absolutely. Most likely underlying complete heart block. Because if it were conduction, there would be some conducted QRS complex. Except in some situation that if somebody has AFib with slow ventricular response and the pacemaker is programmed at 78-minute pace. So a lot of times when I bring this patient, I will slow down their pacing rate and see if there is any underlying rhythm, just to look at it. Thank you. Anybody else, any comment? Somebody else wanted to say something.
Dr. Motin raised hand. Kamrul.
So I have a query, sir. Like this AF with slow ventricular rate and sick sinus syndrome. Sometimes like we get confused in ECG, sir, whether it is a part of sick sinus or it is just AF with slow ventricular rate, sir.
Okay.
So how do we
Sure. So the sick sinus syndrome, you have to understand. Sick sinus syndrome was diagnosed, this term was coined by this lady in Fourier from Argentina many years ago, mid-70s. To call sick sinus, it must have sinus function. I mean, the pattern is sinus bradycardia, SA block, bradykardia. But once somebody goes into permanent AFib, I try not to use the diagnosis of sick sinus syndrome anymore. It's mute because sinus function is not there anymore. So I usually refrain from that. Also, other parties, you have to also understand that a lot of people have AFib without having sick sinus syndrome. So that's the thing. Thank you.
Thank you, sir.
All right, Paul, please, this should be a quick one. Did you put the poll? Okay.
Mhm.
Majority said atrial sinus ventricular paced rhythm, sinus rhythm with left bundle branch block, ventricular paced rhythm, accelerated idioventricular rhythm. So accelerated idioventricular rhythm is a choice, but as there is pacing spike before each QRS complex, that choice is out. Again, sinus rhythm with left bundle branch block, each P followed by a pacing spike and a QRS which looks like left bundle. So this must be generated by the pacing. So it's not that. Atrial sinus ventricular paced rhythm and ventricular paced rhythm both are correct diagnosis because it is a paced, but more accurate will be that because each P is followed by a pacing spike and QRS complex, it must be synchronized with the atrium. So appropriate, correct answer will be atrial sinus ventricular paced rhythm. If somebody answers both, let's say there are two students, one answers atrial sinus ventricular paced rhythm and ventricular paced rhythm another person, I will give 1 point to this person, maybe 2 points to this, but both of them will pass my exam. Because, yes.
I have one question.
Yes.
Here, the QRS complex is positive in case of V5 and V6.
Yes.
But most often we find that the QRS complex will be negative in here.
In V5, V6.
Why is the difference?
Okay. So it's not an uncommon finding. Let me see what my previous ECGs were. Look at this one. Lead 1 is typical left bundle, but lead V6 is negative. What happens is that when you put the lead in, the right ventricle goes under the left ventricle. And if your lead is sitting near the apex of the ventricle, where the V6 is, the electricity is moving away from V6. And that's why you get this negative complex. If you find negative and with right bundle, then we always think of perforation sometimes. So that is the I think the most likely explanation. The other part is that if I put a V7, V8 lead, you will end up getting this left bundle pattern ECG, typical left bundle.
And if you put this lead, like nowadays we do his bundle pacing, how the QRS is going to look like.
We'll bring that later on because his bundle pacing will produce natural QRS complex.
Sir, this is possibly septal pacing, sir.
No, this is all pacemaker. This is just regular because septal pacing, the QRS is very wide. In septal pacing,
that will be narrow.
Narrower QRS.
The 2 and 3 is positive, sir.
What is it?
2 and 3, 2, 3 AVA positive.
Yes, that's the part. Again, I think it's the function of which way heart is rotated. You're absolutely right. Yeah. How about this one? I'm giving the same choices again and again, just to make sure that
learning.
Yes. And bring up the point that a lot of times we will see spike, a lot of times we will not see pacing spikes. Maybe it's left bundle, who knows? So poll, please. Where is this poll coming from? These two questions.
Kamrul?
Just put the first one. Yeah, okay, that's good.
Okay.
Okay.
So at least this time there is no idioventricular rhythm, but this could have been a better choice for idioventricular rhythm because I cannot see the spike that well. So let's look at it. What I've done is magnified lead V1, and you can see there is a pacing spike before P wave here. And then V4, if I magnify it, there is a pace, it's very tiny. So it's AV sequential paced rhythm. In V1, you cannot see the spike. In other leads, you cannot see the spike. If I see this one, it will be very difficult for me. I can call it sinus rhythm with left bundle branch block, but not in other leads. This one, Paul, please. Why are two choices coming up?
Yes, right.
Athar, you know that ECG that has positive in 2,3 AVF, and absolutely it is possible that it's the apical septal pacing, because if it is apical septum and the lead is a little higher, then it will become positive in 2,3 AVF.
Right, sir.
One that you mentioned. So sinus rhythm with first degree AV block, old septal MI, sure, it's a correct diagnosis. Sinus rhythm with majority said number 2, number C, atrial paced rhythm with septal MI, ectopic atrial rhythm. So if you look at majority of the P waves, they are basically sinus P wave, but there is only one paced beat. And that's what we are talking about. So there is one paced beat and then rest of them are sinus because of the timing. So the answer is sinus rhythm with first degree block, occasional atrial paced beat. And I just added the old septal MI. Look at this. What I have done, when I have put ectopic atrial rhythm, I did not put the old septal MI. And that's the way you prepare questions. And you see if your student has this, understand the trick of it. All of them has old septal MI, except one. And there is a finding of old septal MI. And so if I were answering, I would immediately exclude this one. I said, look, there is no old septal, there is a old septal, all of them has, and then I'll choose one of them. Atrial paced rhythm, if that was true, then it should have been pacing spike on all of them. But there is not, just one has. And sinus rhythm with first degree, if that was correct, then I would have none with atrial pacing spike. So the choice is 2, by diagnosis of exclusion and of course by finding. And the same patient, what's going on with my machine? At other time, you can see that now it's atrial pacing all the time. So it goes depending on the rate. It's set at 50 beats per minute. When the rate goes over 50, it paces, it conducts normal sinus beat, and then below 50, a lot of times we will program pacemaker to 50 to conserve battery life, and depending on the need of the patient. This one, please. First, look at the picture and also pay close attention to the question choices also. Okay.
Excellent, sir.
Sure. So
Hmm.
I will address the A first. Sinus rhythm with first degree. Clearly, there is first degree, but each P wave, there is a pacing spike. All of them. So sinus rhythm first degree wave is not a choice. Atrial sinus ventricular paced rhythm, of course, is a choice, but there is also pacing spike before each QRS. It's a very fine pacing spike. Every sequential paced rhythm is a choice. But if you look at the PR interval, here it is long, and then as we go, it is short. And this is a mechanism that is built in some of the pacemakers. And if we turn the pacing feature on, what it does, every so many beats, it will look at prolong the PR interval to see if there is a conducted QRS complex. Now, you don't want to program this search in patients with complete heart block. We do this in patients with 6MS syndrome to minimize ventricular pacing. One, to conserve battery. Second, ventricular pacing can worsen LV function, and we try to minimize ventricular pacing. And this is the same patient with an intracardiac recording. You can see that long PR, and then after a little bit, it goes back to the short. And then it will come back after so many beats. Again, it will keep searching for intrinsic conduction. But I will caution you, if you have this feature in your pacemaker, if the patient is complete heart block, don't put this feature on, because it is just wastage of battery or whatever it is trying to do. It's not necessary. So this ECG, yes, let's do this, and then I would like somebody to come and talk to me about it. Paul, please. Okay. Interesting. Okay. Let's start with the
interesting ECG.
With number one choice, atrial fibrillation with ventricular premature beat. The term is called premature beat. Even if this was a ventricular beat, it is not premature. I would have put it as a ventricular ectopic beat. I did not. So it's not a random choice. So this is very long coupling. However, and then this interval is 1, 2, 3, 4, 5 is 50 beats per minute. There is a pacing spike before this. And this is 1, 2, 3, 4, 5, 60 beats per minute. So that's why I put two choices: atrial fibrillation with ventricular pacing with abnormal pacemaker function, because sometimes it is slow, sometimes it is fast. Or is it hysteresis? It is pacing hysteresis. What we sometimes do, patients who had AFib or periodic slow heartbeat, we say, well, what we'll do, we'll put a single chamber pacemaker in, put a hysteresis rate of 50 or 40, so that if the heart rate goes below 50, here you can see it starts pacing and then paces at a rate of 60. And then once the rate goes over, it goes back. And again, this is minimizing. So this is normal pacemaker function. And the diagnosis is again atrial fibrillation with ventricular pace beat with pacing hysteresis. Was there any comment on that?
This ECG actually shows how the pacemaker works and how you minimize ventricular pacing in a case of atrial fibrillation.
Yeah, thank you.
Because very often people just put, without any history, they put the pacemaker at a rate of 60 or something like that. But your patient will do very well with 50 in case of atrial fibrillation. So
Yeah.
why should I?
And malfunction, another thing. If you want to comment on the malfunction, the reason is either unable to capture beat or unable to just fire it, but it is firing and capturing. So that's probably not there. So
sure. The other reason you put history is nighttime. When patients sleep, their heart rate is low, and you don't want to pace during nighttime unless it is absolutely necessary. So this one, please look at it and this time I would like somebody to come and talk to me about this. Okay. So majority said one. Anybody wants to come forward and talk to me about this?
So may I try?
Sure.
So this looks, we can see clearly pacing spikes before QRS, and before P wave, sometimes we can see spikes, and sometimes spikes are there without capturing two P waves.
Okay.
So, and even sometimes this atrial spikes are coming after shortly after P waves also.
Okay.
So I think there is failure to sense as well as capture the atrium. It is dual chamber, and it is both failure to sense and capture both.
Okay. So then why did I put this choice of sinus rhythm with Wenckebab block? Look at this. If I look at this ECG, long PR, and maybe there is a block P wave and there is a short PR. And that was the reason I put this thing. It is true, it is abisequential paced rhythm is a correct diagnosis. Failure to capture is a correct diagnosis, but partially correct. And then let's look at it, Manoj, what you said. What I have done is this, I have expanded this part. There is a pacing spike, but there is no P wave after that. So atrium did not capture, and there is a ventricular pacing followed by capture. And then there is a P wave here. Even then, there is a pacing spike in the atrium. That means pacemaker did not sense this P wave. So there is a failure to capture, failure to sense in the atrium, both present. Now, one can question, how about this one? Did it capture? So there is a little gap. And also look at this. This is the beat, which is this, and their gap is not there. But I also did something else. What I did, I measured the P2P interval. If you look at the P2P interval, this is 1080 millisecond. This P to this P, 2160, that means exactly double of P2P interval. And then this P to the 1060. So these P waves are independent of this atrial pacing spike and no change in timing at all. So there is absolutely no atrial capture. This is the atrial capture failure and sensing failure. And you have to make sure that you identify this rhythm, because this pacemaker, there are a couple of possibilities that you can have sensing failure because you did not program it right. You can have capture failure because you have a high threshold. Let's say the threshold is 2.7 and you programmed it 2.5. But it is very difficult for me to believe that the two things can happen at the same time. And this lead must have dislodged. Now, is this a fractured lead? No. If this was a fractured lead, you will not see any pacing spike at all. So please remember that if the lead is fractured, you don't see any pacing spike at all. There are two more ECGs and we're going to talk and then probably we'll be done. So let's do the poll again. So nobody said sinus rhythm with right bundle, which is good news. AV sequential preterm, normal pacemaker function. Dual chamber pacing with atrial failure to capture. Okay, let's look at it. So lead V5, I have expanded that. If you see this spike, there is no P wave. There is a P wave somewhere here later on. So there is this A probably has captured. This one did not. And then in V5 again, another point here that there is a P wave. It didn't see the P wave. So there is failure to sense and failure to capture, probably intermittent failure to capture because this P looks captured. And then this randomly keeps putting this atrial pacing back. And then there is a QRS complex, there is the ventricular. And here, atrial pacing, ventricular pacing. So it's this one again is failure to sense and intermittent failure to capture. I'm going to skip this one. This is a patient who presents with presyncope and has a dual chamber pacemaker. And you can see that there is nothing basically, except there is one pacing spike here. We don't know whether it's captured the P, but there is no ventricular pacing at all. There is a P wave. And this patient actually had a fractured ventricular lead. And the atrial lead was working because it paced here and the rate is faster than the base rate. So it didn't. So this one, right bundle, left anterofascicular block, is the old pacemaker. We just went ahead and put a new lead in. This is an interesting ECG that I would like someone to comment if you can. From the audience, anybody? I mean, I'll tell you the question. What I have is that atrial pacing, ventricular pacing. It is AV sequential pacing, atrial pacing, ventricular. But here, there are two spikes, A and V, on a QRS complex. Is this a normal function or is it abnormal function? So there is a feature built in pacemaker. So this AV interval is 160 milliseconds, but when this thing happened, it is 110 milliseconds. So what pacemakers have a built-in feature that if after atrial pacing, within the blanking period, if there is a sensed QRS complex, ventricular is pace instead of inhibit, and it's called safety window pacing. And many, many years ago, it used to be called 110 phenomena. When pacemakers, we used to see these things in older pacemakers in the mid 80s, late 80s. What will happen that there is atrial pacing in a complete heart block patient, that spike is sensed by the ventricle and it inhibits the pacemaker. And there will be asystole despite the fact that the patient has a dual chamber pacemaker. To prevent that, pacemaker, there's incorporated in all pacemakers that if during the blanking period, there is a sensed event within the PR interval, program PR interval, any sensed ventricular event, it will pace the ventricle instead of inhibit it. And it's called safety window pacing. I think this is another patient. So look at this. So there is atrial pacing. There is ventricular pacing, but no capture. So what is the problem? The problem is the lead is not fractured. It is delivering spike, but it's not adequate enough to capture. So either the threshold has gone up, or maybe the lead has perforated and gone into the pericardial space, and it's not capturing. But lead integrity itself is present because of there is spike. Thank you. I think we're done. If anybody has any comment or you want to say something, I think we should finish here today.
Last two are very intriguing, sir.
Yeah, thank you.
Wadubhai, we have got Dr. Aparna Raman from Uttara Women's Medical College. Dr. Aparna, can you hear us? Dr. Aparna? Actually, Uttara Women's Medical College joined with us today.
Sure.
That's good.
Thank you all. Whether you can comment and then we can finish.
So, Wadubhai?
Pacemaker ECG, very often even senior cardiologist asks me, sometimes the perplexing ECGs are there. Particularly the last two are the examples of how pacemaker ECG can make a flummoxed. You'll be astonished to find out what's wrong and what's not. And the best way today, sir has shown how to explain these things. What we do when we find such ECG, we share it with other friends or colleagues or senior colleagues, and then try to understand what is actually happening. I would ask the youngsters, whenever you find an interesting ECG that you cannot actually understand, please share it with your elders or your colleagues, and even post it in our ECG study group or whatever, and you will find out some answer is there, and that will actually enrich you.
Thank you, sir. Assalamu alaikum, sir.
Aparna আসছো? হ্যাঁ বলো ভাই।
Aparna, this is
Sir, কেমন আছেন স্যার?
Hello, ভালো সবাই?
জি স্যার, আলহামদুলিল্লাহ স্যার। স্যার খুব এনরিচ ছিল স্যার আপনাদের লেকচার। এরকম লেকচার আসলে স্যার আমরা আমরা খুব আসলে লাকি স্যার, আপনাদের মতো টিচার আমাদের সাথে ওয়েবিনারে জয়েন করছেন। We are very much thankful to you, all of you, sir.
Thank you.
Thank you, Aparna, for your joining with us.
Arun is here.
Yeah.
ওয়াদুদ স্যার ভালো আছেন স্যার?
ভালো আছি ভাই। Arun,
Maski.
when are we going to see you?
This Pisal is coming on Wednesday.
Yeah.
So we'll see you. As usual, there's nothing much to talk. These are very helpful classes. In fact, I forgot this pacemaker ECGs. I'm just recalling a lot of things from you. Thank you.
Manoj, I like your hairstyle.
Ashok
didn't hear me.
Thank you, sir. Thank you, sir.
Sure.
মাঝখানে অনেকগুলো lecture I have missed, but today I have learned a lot from Rafiq sir. So as usual, I always enjoy Rafiq sir's class. Thank you, sir.
Welcome. Thank you.
So, Adudbhai, please wrap up the session.
We have an announcement. We're going to have a in-person session in November, mid-November, 17th November, Thursday, at Dhaka Medical College Milan Auditorium, where Rafiq sir will be also present. We'll have a session starting from 2 in the afternoon till around 8 or 8:30 p.m. in the evening. So there'll be multiple lectures, and I hope our audience, or those who are able to come, will enjoy the sessions.
Date আবার বলেন স্যার?
17 November.
স্যার রেজিস্ট্রেশন লাগবে কোনো স্যার?
না লাগবে না। ওটা অবশ্যই ECG মানে এইটা ওই আমরা করে দিচ্ছি। ওই রেজিস্ট্রেশন অনলাইন রেজিস্ট্রেশন ব্যবস্থা করবো হয়তো।
Online registration.
Beksunko Romel is here. Nabila, are you here?
Yes, sir, I'm here.
I think Nobel is also present. Is it? Rumen?
No, sir. No, sir. He's
Acha,
not.
alright.
I am
So
conducting.
they will be coordinating the whole thing.
Okay, sir.
তো
Today,
আমি কি আমার এখানকার মানে এরকম কোনো বাইন্ডিংস নাই যে এভরিবডি রেজিস্টার অ্যাসিস্ট্যান্ট প্রফেসর এন্ড অল দা
না
কোন রকমের বাইন্ডিংস নেই অশোক দত্ত, এভরিবডি ওয়েলকাম। এবং আমরা কিন্তু যে মানে
আমরা
অনলাইনে
কিন্তু এরকম এনজয়েবল সেশন করতে চাই যে সবাই মিলে, এবং আমাদের টার্গেট কিন্তু মেইনলি junior doctors,
juniors,
senior students, internee doctors, resident doctors, and trainee doctors. They'll be the main important audience. And another thing is that I'm the chance. Aziz Bhai will be coming to Bangladesh, so I hope on 15th of this month we are going to have some lectures on heart failure case-based discussions that will be happening on SGM Chaudhary Memorial Hall in Dhaka Medical College on 15th. At 11 a.m.
This 15th, yeah.
15th of
this month. And that will be 17th November when Rafiq sir will be in Bangladesh.
15th October, sir.
This is 15th October. It is SGM Chaudhary Memorial Hall.
Next Saturday, right?
Yeah.
All right. So thank you all.
Thank you, sir.
Take care.
Thank you, sir.
See you.
Yes,
Bye-bye.
sir. Assalamu alaikum. Good night. Thank you, sir.
Next
Thank you,
session,
Rafiq Bhai, for nice lectures.
Abdullah Jamil, 23rd. Jamil.
Arun, give my number to